It is a pleasure for me, I'm Claudio Doglioni, introducing this webinar that will be held by Professor Nicola Fusco. Nicola Fusco is a professor of pathology at the State University of Milan, Italy, and he is director of the Division of Pathology of the European Institute of Oncology in Milan. The European Institute of Oncology, founded 30 years ago by Professor Umberto Veronesi, rapidly became an international clinical referral and research center for breast cancer. This institute proposed and participated in most of the clinical trials, leading to the major improvement in breast cancer treatment. HER2 had a central role in the therapeutic revolution in the early 2000s, and we, as pathologists, we learned a lot how to diagnose and select patients with HER2 amplification and overexpression for anti-HER2 therapy with trastuzumab. But now HER2 therapy has a new potent drug, an antibody conjugated drug, ADC, trastuzumab deruxtecan, that demonstrated high efficacy in a different category of breast cancer, the HER2 low breast cancer, with recent clinical trials demonstrating a dramatic improvement in patients with metastatic breast cancer. So a new life of HER2 as a predictive biomarker in breast cancer. And pathology is where HER2 evaluation is performed. And Professor Nicola Fusco, the director of the pathology division of the European Institute of Oncology, with his great experience on this topic, will tell us why and how we have to engage in this new field. Good webinar. Professor Fusco, at you.
Thank you, Professor Doglioni. Thanks for the introduction and for the kind presentation. And I extend also my gratitude to all of you that are attending the meeting, this webinar today. And it is a pleasure for me indeed to discuss about HER2 testing. That is a crucial type of analysis that is performed in breast cancer, and now with the expanding therapeutic opportunity, as Professor Doglioni was mentioning before, this testing is becoming more and more important, and the role of pathology and pathology technician also is growing as well. So these are my disclosures. And let's start talking about HER2, which is a membrane protein, is one of the 4 growth factor receptors that are present in humans, and actually can be defined as the unlucky brother among the 4 of them, because HER2 is usually only slightly activated in normal cells. And the extracellular domain, in fact, is composed of 2 subdomains that are usually not or slightly activated. That's why the presence of overexpression of HER2, and usually overexpression is due to gene amplification, is an abnormal condition that leads to cancer growth, tumorigenesis, tumor progression, and resistance to therapies. And indeed, HER2 is the first starting point of several pathways that lead to growth and tumor progression. So the point here is that HER2 testing has become extremely important in the past, because we had the first targeted therapies in solid tumors of the history. It was with trastuzumab in patients with HER2 amplification. And now, as Professor Doglioni was mentioning, more opportunities, particularly with the antibody-drug conjugates, are entering into the clinical practice. And in particular, in breast cancer, HER2 is extremely important. It is an oncogene, and of course, it has a positive predictive value for trastuzumab and trastuzumab deruxtecan therapy and antibody-drug conjugates in general, targeting HER2, but it is also a prognostic factor. So tumors harboring amplification of HER2 usually are more aggressive than HER2 negative tumors. But how many breast cancers are HER2 amplified? It is estimated that approximately 15% of breast cancers display HER2 amplification, but this is a general percentage taking into account all the different subtypes and not stratified by other characteristics, including the demographic characteristics. But worldwide, 50% of breast cancer harbor HER2 overexpression or amplification. So we have the clinical rationale for testing, and how to perform this type of testing according to the ASCO-CAP guidelines. First of all, we have two different types of testing strategies that are based as frontline immunohistochemistry with antibodies anti-HER2, and we have also a reflex molecular test for a subset of tumor, that is the in situ hybridization. So immunohistochemistry uses antibody anti-HER2. It can be either monoclonal or polyclonal. Usually the monoclonal antibody are those that are particularly employed in the clinical practice, and is scored according to the percentage of cells that express HER2 in the membrane, but also takes into account the intensity of the staining and the pattern of staining, meaning that the continuous strong expression of HER2 in the tumor cells gives a immunohistochemical score of 3+, whereas with faint and lower expression, we have 2+, 1+, or 0. Traditionally, the HER2 positivity was defined by the presence of a score 3+, or by the presence of a score 2+ with positive in situ hybridization. All other tumors were dichotomically considered HER2 negative. So HER2 negative were score 0, score 1+, and score 2+ with no amplification of the gene. What type of testing we have to perform for the 2+? We have to perform a validated in situ hybridization assay, at least in Europe. We are not linked to specific in situ hybridization strategies, so we can perform the fluorescence in situ hybridization, silver in situ hybridization, or chromogenic in situ hybridization, and based on the proportion of signals for HER2 and the proportion with the centromere, we can define the amplification over the non-amplification. But now we have to take into account also the entire immunohistochemical spectrum, because HER2 low invasive breast cancer have become clinically relevant for the treatment with antibody-drug conjugates. So HER2 low breast cancer are defined by a score immunohistochemistry 1+ or 2+ without gene amplification. So with this distinction, we have the score 0, the HER2 low that takes into account 1+-ish negative, or positive, 2+-ish positive, or and 3+. These tumors, the tumors that display low expression of HER2, are approximately 50% of all invasive breast cancers, and can belong to the luminal or triple negative subgroup, and they are usually more frequent in the luminal subgroup, and they have a poorer prognosis compared to HER2 negative breast carcinomas, but the HER2 expression is not related to the amplification of the gene. So HER2 low, if we consider only the hormone receptor positive subgroup of breast cancer, compass 60 to 65% of cases, and the cutoff percentage of tumor cells is to display a faint or incomplete membrane staining, or weak to moderate complete membrane staining, is 10% for score 1+ and 2+ ish negative respectively. But if we observe, if we analyze more closely the data of HER2 low frequency according to the expression of hormone receptors, we can see that in hormone receptor positive, 55, but as I showed you, up to 65% of cases are HER2 low, whereas triple negative, less than 40% of cases, approximately 35–38% of cases are HER2 low. So this observation provides further credence to the notion that HER2 and hormone receptors have an interplay in tumorigenesis and tumor progression, because HER2 expression is substantially linked to the expression of hormone receptor, and in particular estrogen receptor. The definition of HER2 that takes into account the percentage of tumor cells and the patterns of membrane positivity and intensity is intrinsically embrace a concept that characterizes breast cancer. It is the concept of heterogeneity. So there is a great intratumoral heterogeneity of HER2 expression, and this heterogeneity can be of different types according to the spatial distribution of HER2 amplified cells or HER2 positive cells, but also HER2 low is heterogeneous by definition, and the heterogeneity is not only related to the primary tumor, meaning intratumor heterogeneity, but is also linked to the tumor evolution. And we may have a shift of phenotype between primary tumor and metastatic sites, both in hormone receptor positive and triple negative breast cancer, with score 0 that primary tumors that have HER2 low metastasis, and vice versa, HER2 low primary tumor that are negative, completely negative, score 0 in the metastasis. This heterogeneity is also confirmed if we study the expression of HER2 by mRNA, and the heterogeneity can affect not only the biology of the tumor and the treatment of the tumor, it can also affect the testing of the tumor. For all of us that work in pathology, we have to be perfectly aware that we are not talking about a new molecular subtype of breast cancer, a new biological entity, but we are talking about a new version of the clinical value of a test interpretation. So the HER2 low is not a biological subtype, but is a diagnostic strategy. And this is extremely important because while the guidelines for HER2 testing have not changed, over the past 15 years. What has changed is the clinical rationale for the testing interpretation, and that's why it's important to take into account the possibility that in the past the distinction between score 0 and score 1+ was not clinically relevant, so the sensitivity of this type of distinction was low, but now that is relevant, we should be able to perfectly distinguish between score 0 and score 1+. And the clinical rationale that drives our pathological diagnosis is related to the very pharmacological mechanism of antibody-drug conjugates and trastuzumab deruxtecan in particular, in which we have an antibody that is charged, monoclonal antibody, anti-HER2 monoclonal antibody that is charged with chemotherapy agents, cytotoxic agents, so that the monoclonal antibody is able to bind the target, HER2, even in the absence of gene amplification, and release in the tumor area the cytotoxic agents, thereby having a cytotoxic activity. Also in the HER2 negative cells. And this effect is called bystander effect, and is for this reason that HER2 low has become extremely important. Since 2022, when the results of the DESTINY-Breast04 were presented, and a standing ovation was took place in Chicago during the ASCO meeting. Just 1 week ago, we were again in Chicago, 2024 ASCO meeting, and the results of the DESTINY-Breast06 were presented by Professor Curigliano. And this has changed again our definition of the clinical rationale for HER2 testing, because with this new clinical study, not only HER2 low tumors were studied and demonstrated activity of the drug, but also HER2 ultra low. What does that mean? It means that according to the ASCO-CAP guidelines, HER2 score 0 is defined by the tumors that have no staining for HER2, of course in the presence of a positive control, internal and or external positive control in each slide run, or tumors that have a membrane staining that is incomplete and faint or barely perceptible in less than 10% of the tumor cells, less or equal. So again, the 10% of cutoff is important. So within the HER2 score 0 category, previously considered substantially negative, we have a subset of tumors that have a faint expression of HER2 in less than 10% of the tumor cells. These tumors are the ultra low and actually comprise 20 to 25% of cases, and in addition to the 60 to 65% of cases, we can observe that the vast majority of breast cancer are eligible for the therapy with these new antibody drug conjugates. So at present, the situation is that we have 3 diagnostic categories that have different clinical management possibilities. The HER2 amplified, either score 2+ or with amplification, or 3+, that can be treated with target therapy, conventional target therapy, trastuzumab. The HER2 low and ultra low that demonstrate effect with antibody drug conjugates, trastuzumab deruxtecan, and the 0 with null expression of HER2 that cannot be treated with target therapy, either antibody drug conjugates or conventional target therapy. Given that we now have different clinical rationale, it is not surprising that historically HER2 score 0 can be re-scored according to the new indications as score 1+. And also that within the score 0, we should report in the pathology report whether it is 0 null or if there is a faint, barely perceptible positivity in less than 10% of tumor cells. And particularly while evaluating historical samples, as these drugs are presently approved in the metastatic setting, the historical samples can be rescored, provided that we put a note in the pathology report, which we specify to our patients that their guideline is not changed, but the clinical rationale has changed a lot. Of course, to be confident with our analysis, we have to be perfectly confident about the pathology workflow, in which the pre-analytical, the analytical, and the post-analytical phase play a crucial role. So the time of fixation, but also the cut, the thickness of the sections, and in general, the tissue processing is extremely important. It's extremely important also the logistics, and of course the HER2 testing process should be compliant using CVD marked assays or validated assays, regardless of the staining platform. The most widely employed are the Ventana and the DACO instruments. But the post-analytical phase is as important as the pre-analytical and analytical phase, as there are different challenges that actually are shared with all the biomarkers that have a predictive test that is immunohistochemistry based, such as PD-L1, for example, and that is related to the heterogeneity of the different antibody and detection systems, and of course, different staining platform. The different scoring systems, particularly for those of us that use Ventana, and also the biological heterogeneity, that is the spatial and temporal heterogeneity. So in this respect, HER2 testing remains crucial, but is gaining complexity. I liked a lot this slide that was presented during the discussion at ASCO of the Destiny Breast 06. And it gives the idea of the fact that we are presently asking a lot to our good old HER2, as the test was originally designed basically to screen for the amplification. So the immunohistochemical reaction of HER2 score T plus is has a high degree of saturation. Therefore, it was not designed to detect low expression. And that explains the preliminary data that show that even in the score 0 category, antibody drug conjugates trastuzumab deruxtecan is effective. But it's not effective because it's effective regardless of the biomarker. It's effective because there's an expression of HER2, but with our diagnostic device, we cannot detect or detect it as a faint, barely perceptible expression. So I can say that the current immunohistochemical testings are poor in distinguishing HER2 low and even in distinguishing HER2 ultra low from score 0, null. Therefore, new assays should be developed, immunohistochemistry, but particularly mRNA-based. Regrettably, these new assays should be validated clinically into the clinical trials and analytically in our own laboratories. So harmonization studies and reproducibility studies are on the way to validate new assays. If the preliminary data that HER2 score 0, null can respond to trastuzumab deruxtecan will be confirmed, it is likely that it will be come back to the original situation in which we have HER2 amplified tumors and then all the others. For the moment, however, the HER2 score 0, null, we do not have sufficient data for translating this into the clinical practice, but we will wait for the new clinical trials. What we have to put in place is a perfect diagnostic workflow in all analytical and pre-analytical phase, but also we have to provide a pathology report that is compliant with the new ASCO-CAP updates and ESMO consensus for the testing of HER2 that basically confirm the guidelines but add an additional layer of complexity that is related to the clinical value of the test. But HER2 is not only altered by means of gene amplification. We can also have somatic mutations in HER2, particularly in the tyrosine kinase domain, but not only. We have a couple of hotspot regions in the tyrosine kinase and the furin-like domain, but again, HER2 mutations are not part of the clinical practice, but can explain the cases in which, despite the protein expression, we do not have sufficient responsiveness to the new treatment strategies. So HER2 mutation often occurs as a selective pressure due to anti-HER2 therapy and are a resistant mechanism, particularly in patients with bone metastasis. And actually the bone is also a particular site of metastasis that may affect our capability of detecting low expression of HER2, because bone biopsies are often managed using processing procedures that can be aggressive, particularly for tissue decalcification, and therefore they deserve a specific attention. In this last part of my lecture, I would like to discuss with you about the perspective that artificial intelligence is providing, in particularly for the standardization of the test. And actually, there are several machine learning based algorithms that can help identifying the correct percentage of positive cells, specifically for HER2, but also the cells that have a faint expression, thereby empowering the identification of HER2 low and, most importantly, ultra low breast cancer. However, these algorithms are currently under validation and they cannot be employed in the clinical practice. This was my last slide, and I thank you all for your attention, and I'm available and eager to discuss with you about this topic. If you have any questions or comments, please share. It's my pleasure to discuss with you. I believe that in this type of field, we have to be aware of the value that our work as pathology is gaining, and HER2, we are asking HER2 again to bring value to our profession, and that's why we need full support about the pathology community, and also a full support about also the industry. We have a question. HER2, whether it can be detected in persons with no symptoms, but genetically they may carry the gene. Okay, maybe this question, if I can rephrase this question, maybe our colleague is asking if HER2 can be detected also in other tumor types rather than breast cancers, and if HER2 amplification can be present also in the normal cells in patients with no tumors. Yes, the first part of the question is a very solid rationale, and actually yes, the HER2 can be amplified in other tumor types, particularly in stomach cancer, gastric cancer in general, non-small cell lung cancer, and it's clinical part of our is part of our clinical activity, HER2 testing also in gastric cancer in particular, with specific guidelines that are slightly different from those employed in breast cancer. Whether HER2 amplification can occur also as germline alterations without leading to tumor, I'm not sure, because HER2 amplification, gene amplification are usually not inherited, but activating mutation may be inherited. However, HER2 is not a gene related to a cancer syndrome, but HER2 can be overexpressed it is an exceedingly rare situation, but can be overexpressed in some other lesions of the breast that are considered non-obligate precursors to breast cancer. However, this overexpression is often not driven by an amplification.
I have a question also for you. Can I?
Yes, absolutely.
The history of HER2 and the drug trastuzumab in breast cancer started with metastatic breast cancer. Also, this new drug started with metastatic breast cancer. Do you think that also as a trastuzumab in breast cancer that is overexpressing or amplified, that move to adjuvant, then neoadjuvant setting? Do you think that the same could apply also to this new drug?
Thank you for your question, Professor Doglioni. And actually, I believe that yes, given the outstanding results that trastuzumab deruxtecan has demonstrated in the metastatic setting, I believe that also in the early breast cancer and in neoadjuvant setting, there would be a clinical value for this type of therapeutic strategy. And in particular, we are eager to see the results of the DESTINY-Breast09, hopefully in the upcoming San Antonio Breast Cancer Symposium, that maybe we shed light on at least the early setting.
Thank you. And thank you, Professor Fusco, for this excellent and brilliant presentation. Thank you very much.
Thank you, Professor Doglioni, and thanks to all the attendants, and also to our sponsor, Diapath, that allowed us to spend this couple of minutes together discussing of this interesting topic.